It is straight up top of the hour. Hi, I'm Dr. Lewis Meltz and representing MedXPrime. This presentation is for healthcare professionals or associates with us to find out a little bit more about what pharmacogenetic testing is, MedXPrime, and how this can affect not only your patients and your practice. So let's get underway. This presentation is for medical doctors, osteopaths, physicians assistants, nurse practitioners, and all other licensed healthcare professionals. So a warm welcome and thank you for your time today, whether it be lunchtime on the West Coast or mid-afternoon further across the country. You're going to find out what MedXPrime has to offer. And essentially, our mission is every doctor and every patient. Our scientific advisory board is combined with people with many, many years of experience. Dr. Paul Rosatero, 20 years, an Air Force flight surgeon. Dr. Michael Carter, bariatric specialist. Dr. Doug Tuman, a podiatrist. Dr. Viv Chander, Dr. Ted Chandler, Dr. Raj Mahal, myself. Hi, I'm Dr. Lewis Meltz, all part of the scientific advisory board for MedXPrime, helping lead a pathway in which we are developing and helping to find new clinical partners to expand our vision of every doctor and every patient. I'd like to introduce our Chief Medical Officer, Dr. Peter Dimitri. He is a former Assistant Surgeon General of the Air Force and fighter pilot, having implemented novel technologies over a $6 billion global healthcare initiative into both the Department of Defense and Veterans Administration. He too embraces our mission of every doctor and every patient. So let's get started here. First of all, it's not just the Mayo Clinic that understands the importance and the efficacy of pharmacogenetic testing. They do it. Why? Because it improves their risk management and it minimizes their liability when it comes specifically to adverse drug reactions. Now, we also know that the number 2 cause of death in the United States today is simply drug overdose. So we can see the importance of not only having other representatives that use this test, but use it routinely. And it's not just the Mayo Clinic. Duke, Vanderbilt, Johns Hopkins all use pharmacogenetic testing to improve their model of care. Early on, it's more important to know what sort of person has a disease than to know what sort of disease has that person. That quote is thousands of years old. Much like other problems, if it weren't for the great variability among individuals, medicine might well be a science and not an art. And we understand this all too well when we see the changes that our healthcare efforts result in and the different people that present to us. Now, we know that pharmacogenetics is the study of genetic variations that influences individual response to drugs. And it's that science that allows us to predict a response to drugs based on an individual's complete genetic makeup. No one is the same. No one who's ever walked this earth before us, presently or in the future, will have the exact same genetic makeup. Doesn't it make any sense that people would respond differently to drugs? We've always known when prescribing drugs what it should do in an individual based on the pharmacodynamics and the pharmacokinetics of that medication. The one thing that's been left from the equation is what that drug is going to do in the individual we're giving it to, simply because of the genetic variations in who's using it. This test helps to individualize drug therapy and reduce those drug events, also increasing the effectiveness of drugs by minimizing the competition of receptors between drugs and different drug families. So why should a doctor even consider using a test with their patient? Well, it eliminates that trial and error, the shooting from the hip, hoping that a prescription is going to work, or always wondering in the back of your mind if that prescription written on Friday afternoon is going to result in a 2 a.m. Saturday phone call after someone's been out to dinner or recreationally engaging in other activities that new prescription is affecting. But this is the right drug, the right dose, given the right indication at the right time for the right patient. It eliminates that one-size-fits-all medication management strategy that a lot of providers have practiced for decades. It enhances patient care, patient satisfaction, patient compliance, and confidence. So when you've got a patient who's happy, who's pleased, who's responding to the care being provided, they typically stay on the medication prescribed and they get better. And when they do that, they typically are happy to pay a bill because there's value that they have derived and personally experienced. They also return for new conditions and they refer others. Now, I don't know about you, but in an economy like this, anything that gives you an edge to shore up a practice clinically is a good thing. And at the same time, now you've got patients that stay, pay, and refer. You've also reduced your liability when it comes to ADRs, but you've also improved your risk management. And this is what we call a win-win-win situation for everyone. So it's better, safer drugs the first time around and more accurate methods of determining the appropriate drug class for an individual rather than just guessing. Titrating once, raising and experimenting with dosages and finding out maybe that drug doesn't work. Then you dose them down slowly to try yet another drug and then do that 2, 3, maybe 4 times. This sort of testing allows the first time to understand if someone is a poor metabolizer, an intermediate metabolizer, an excessive, which is considered normal, or an ultra rapid metabolizer, and understanding if they should be dosed at a higher rate or maybe a different solution to be used if they aren't a candidate for that drug class to be used. So we understand that this leads to the overall decrease in healthcare because ADRs are reduced. The number of failed drug trials are reduced. Clinically or research-wise, it takes less time to get the drug approved because you're using a much smaller bell curve of those persons who would respond in the first place rather than having the outliers of the curve skewing the results unnecessarily. Also, we know that the FDA has several black box warnings on drugs that highly recommend pharmacogenetic testing prior to or shortly after initially prescribing the drug. Clopidogrel, Plavix is one of those that has a significant effect on those persons who are unable to manage that drug because of their genetic makeup. But certainly a FDA black box warning drug, most certainly a test like this should be done. There's one thing of performing the test and disregarding the results and not incorporating that into a patient's record. That generally could be considered on liability end of things as negligence. But knowing the test is available and choosing to not do the test and completely disregarding the possible information, although it might require a provider to practice at a higher standard, by choosing not to do the test in the first place because it would offer too much information, that's generally what litigators call gross negligence. It all depends on what decision is to be made, how much information you choose to deal with, and how much risk you are willing to carry in the practice of healthcare. And so why should we care about pharmacogenetic testing? Well, we know that there's over 2 million avoidable ADRs that occur every year in the United States. And of those ADRs, there's 106,000 avoidable fatalities each year. Now, this doesn't even go into mention or recognize those that silently sit at home wondering if they should call 911, wondering if they should call their family physician, wondering if they should have someone take them to an ER room. They just wait it out, seeing if things are going to get better. But we know conclusively 106,000 avoidable fatalities each year. It's the 4th leading cause of death in the United States. And because of that, the relative costs that are attached to it, $136 billion in tangential costs associated with those ADRs. Those that reside in nursing homes are elderly or infirm. 350,000 nursing home ADRs occur every year. What do you think the cost is when it comes to hospital readmissions in the sickliest of the Medicare and Medicaid populations? Well, if you think about what a hospital readmission costs, many of these are for either drug overdoses or for adverse drug reactions. What if those could be minimized? Now we're looking at real tangible cost savings and improving livelihood and improving how a patient will respond. We know that the average Medicare patient takes between 5 and 8 drugs, some even as many as 20. And over 50% of nursing home patients are on 5 or more drugs, with at least one of them being a psychiatric drug. And the more that someone is on a medication, or the more medication someone is on, the greater their chance of sustaining one of these ADRs. 96% greater chance with an individual using 11 drugs or more. So this level of testing can significantly reduce these ADRs even the fatalities that result from these ADRs of drugs being prescribed. So in this chart here, you can see very, very simply what constitutes an ultra-rapid metabolizer, because they have an increased enzyme that would manage that class of drugs, where that drug dosage doesn't even become effective because it's neutralized and eliminated so quickly before it has a chance to have an effect. Extensive metabolizers are those that have a normal level of metabolism, and the therapeutic dosage range are very common and easily experienced. But then you have poor metabolizers, those who are essentially non-functional. And especially for a drug that is a prodrug that requires a second chemical reaction for it to turn into its active form, these individuals would have absolutely no benefit at all. An example of this would be codeine. A poor metabolizer of codeine would never, ever even come close. That's why some people can take a quarter tab of Vicodin and it knocks them on their can, and someone else can take 2 or 3 and has absolutely no effect. And it's not because someone has a greater tolerance to drug. It's simply because their genetics don't allow them to metabolize the drug. You can see here also the various racial groups, African Americans, Caucasians, Asians. They all have different ways in which their genetics allows them to metabolize a different class of drug. Depending on which chromosome is the primary pathway, you can see the selected substrates or drugs and those who are poor metabolizers and the influence it would have on those individuals. Thus, another reason to understand at a better level on how your prospective patients will manage medications prescribed to them rather than shooting from the hip or walking aimlessly blindfolded down the street. Because we have inhibitors, those that turn up or turn down the volume of another drug that turns down the activity because it's inhibited by the metabolism of others. Those that are inducers, those that, for other lack of better words, turns up the volume of another drug and how they interact with each other. And then, as I explained earlier, prodrugs that need to be activated by an enzyme process in order for them to become useful or functional for the purpose they were prescribed. With a prodrug that needs to be metabolized, if we took the 2D6 pathway, for example, codeine turns into morphine, for a poor metabolizer, it'd have poor use, and it would have the accumulation of that codeine before it was ever converted. And you would want to do probably either change medication completely. Whereas if you have an ultra-rapid metabolizer of a prodrug like codeine, it has a very, very rapid effect, and oftentimes it has low therapeutic benefit because the higher the dosage has to go. So this sort of information allows better laser-focused prescription writing strategies. From this table, you can see also that on very, very common drugs or medications, that a poor metabolizer may need a lower dosage as opposed to an ultra-rapid metabolizer someone that would need maybe twice as much to have the same level of therapeutic effect and benefit. So again, the relative utility of pharmacogenetic testing used throughout healthcare and the benefit for patients, whether it be for a cardiac drug, a psychiatric drug, or one to control pain. We understand here's an example, 30-year-old woman, very rare for this to occur, but nonetheless, it does occur. Post-episiotomy, was given codeine for pain, began breastfeeding a healthy infant. 2 weeks afterwards, infant dies of a morphine overdose. Why? Because the woman was a poor metabolizer, accumulating toxic levels of codeine, whereas the infant was not, and through the breast milk got an overdose of codeine or the Vicodin, converted to morphine, causing a death. How would genotyping this patient to the 2D6 gene have benefited the outcome of this case? We understand that it's the classic nature versus nature scenario. You even have twin pairs, and they look at how they handle migraines. And 39 to 58% of how drugs are managed have a genetic contribution, the same as low back pain, 21 to 67% genetic contribution on how those twin pairs will manage the same medication prescribed. So it's a very, very important factor to understand. Clopidogrel, Plavix, another example here. A 58-year-old man was prescribed this drug because of an acute MI. To prevent the ischemic events, he's using this drug. Later to find out that clopidogrel had absolutely no clinical benefit because he was unable to metabolize the drug. So had this individual been tested first for the 2C19 genotypic pathway, they would have understood that they have a genetic variant that reduces the antiplatelet activity of the drug for this individual, and something else would have been better suited in order to prevent a second cardiac event. Study after study after study. Warfarin is a very good example, which most insurance companies will reimburse for, the 2C9 and the VKORC1 pathway, to understand how blood thinning medications work in an individual and in an aging population. We understand that this testing is applicable for 70 to 75% of patients not in a controlled anticoagulation center. So our INR levels need to be checked regularly to understand how to best dose these types of patients and to avoid serious bleeding events. And we know that thousands of them occur every year. With this information allows better dosing strategies. So we can see on and on and on. Here, even a 9-year-old child given the wrong medications and unfortunately had a tragic outcome. By doing this testing in children, in middle age, in elderly, to have a determinate level of outcome with that precision strategy. Very, very simple buccal swab, easily obtained in the office, no more difficult than brushing your teeth. It's sent to the laboratory by prepaid Federal Express. Laboratory tests the specimen, performs the test, provides the results to the doctor, either through secure email, secure fax, or web portal. And with that information, you can then adjust medication, dosage, and provide that one-on-one personalized medicine that most patients today are looking for and desire. So why should we test patients? Well, it eliminates that trial and error. It's the right dose with the right drug for the right indication at the right time. It enhances patient care and satisfaction. If anything, it reduces those adverse events that occur, that improves your risk management and reduces liability. So is there one question only? Once reviewing the risks and the benefits from this testing, why would you not want to do this test? Especially when we understand the benefit it has to patients, benefits it has to a thriving, a stable practice, and also the risk management, liability, and readmission reduction when it comes to a hospital and the most sickly of the Medicare population. So what you want to do next is get back with the representative that invited you to this webinar to get more information. More than happy to set up a conference call and answer whatever questions you have, or a private webinar if you so desire with a larger group, maybe some colleagues that you practice with that want to see this information in greater detail. It's an extremely simple process to set up for your practice, and also some practices which may qualify for an innovative ancillary income program, which we call sharing the professional component of some cytology services offered. Generally, most big box laboratories have never ever shared the professional component with their referring physicians. They've kept the professional component for their in-house salaried pathologists to perform. Our laboratory partner is more than welcome, more than happy to show you how to set up a CLIA certified laboratory to perform your own professional services on cytology specimens and bill directly your patient's insurance for those services done locally and in-house. Thank you for your consideration in implementing using MedXPrime, pharmacogenetic and urine toxicology testing, as well as those ancillary tests available for the TCPC component of cytology testing. If you're interested in participating or being part of our scientific advisory board, please send an email to medxprime@financialhalo.com, and we'd be more than happy to entertain a call and a conversation with you. With that information, went over a little bit over our 15-minute planned conversation. I want to thank you for attending our webinar this afternoon. You make it a good day. Bye-bye.